companies to keep premiums low, but it doesn't solve the underlying problem. It's temporary, and the bill's going to come due eventually.
Thank you, Mr. Merkel. Thank you, Mr. Chairman.
Thank you, Senator Cortez Masto.
Thank you, Mr. Chairman. Before I get into the questions, I want to share some good news about how the IRA is actually helping Nevadans. Thanks to the IRA, 27,900 Nevadans now get approved vaccines for free under Medicare. Over 13,000 seniors in my state have their insulin costs capped at $35 a month. Nearly 100,000 Nevadans saw their ACA health premiums drop by hundreds of dollars each month in the year 2023. Plus, around 4,400 low-income Nevadans are now getting help to afford their prescription medications. Looking ahead, starting in 2025, the year 2025, more than 400,000 Nevadans with Medicare Part D will have their annual prescription drug costs capped at $2,000. This will be a big relief for over 11,500 Nevadans who face high drug costs and are expected to hit the new annual cap. And starting in the year 2026, Medicare will negotiate prices for certain high-cost drugs, which should lower costs for seniors and people with disabilities. That's more than 65,000 Nevadans will benefit from these negotiated prices. And Ms. Aiken, thank you for being here, because you have benefited from the IRA, correct?
Absolutely.
And Mr. Merkel, you would not want to take that benefit away from her, would you? Yes
No,
or no?
there
Thank
are.
you. So let me follow up here, because we've heard from you, but I would love to hear from Dr. Lambrou and Dr. Conti. You've heard this conversation about the IRA. Can you talk about how, listen, I think there are opportunities to always improve legislation, and I'm hoping my colleagues in a bipartisan way will actually want to improve to the benefit of women and men in our states, just like Dr. Aiken, and our children and kids and everybody who should be able to afford health care in this country, including prescription drugs. So you just heard a conversation with Mr. Barrasso, Senator Barrasso. Can you respond to that and talk about the challenges that you just heard from some of the panelists with the IRA, and is there ability to improve upon it, or is there more information that we need to know about the data before we take that next step of improvement? Maybe Dr. Conti, let me start with you.
Thank you. There is evidence that there will be spillovers of direct patient benefit, lower costs, and more expanded use into the commercial insurance sector. But if we want to ensure that commercially insured working men, women, and children get access to the needed drugs they need, we should consider moving, guaranteeing those benefits, also benefit people who are commercially insured. The other thing that I want to make sure that everyone understands is about innovation incentives. There's actually no evidence of differential clinical programs sunsetting because of the IRA. If anything, the industry is looking for opportunities to bring new medicines to market, and that's because they're facing a generic patent cliff in the next 5 years. And in fact, what the IRA does is shifts incentives for companies to actually do parallel trials across many different indications to bring all of those products or all of those indications to market swifter for them to gain as much revenue as possible. That will have significant benefits to Americans. Why? Because they don't have to wait 10 years for a clinical study to be done to show that this drug works for them. Instead, these indications will happen sooner, and Americans will benefit because of that.
Dr. Lambrou, anything else to add?
Yeah, and I think there's an important difference in the Inflation Reduction Act between the drug parts of it and the health coverage parts of it, because in 6 months from now, all the insurance commissioners will be looking to see what do we do, because in 9 months from now, insurers may decide to raise their premiums because in a year from 15 months from now, these tax credits go away. Drug negotiation continues, it expands. The tax credits in the Inflation Reduction Act end in 15 months. What that means is that we will really need to look hard at how we engage Congress on preventing inaction from making this happen. And I would say, I know that there's been discussion of fraud. I know Chairman Wyden has a bill to tackle agents and brokers, those few who are, fraudulently preying upon middle-income people, signing them up when they didn't mean to be signed up. We should target fraud, period, full stop. But getting rid of these tax credits, which have helped 20 million people afford coverage and led to record low uninsured rates in this country, seems like a step in the wrong direction.
Thank you. And I know my time is up, but at the end of the day, the goal here is to make sure that everyone in this country has access to affordable health care when they need it, and they shouldn't be priced out of it. And from a policy perspective and working with my colleagues, if that is our outcome and our goal in this country, then it makes sense we're going to come together to figure out how to make that happen and set these policies that are a positive with that ultimate outcome, and not to put more money in Big Pharma's pocket or the PBMs or any middleman or anybody in part of it. The outcome should be what is good for the individual patient at the end of the day that needs those drugs, that needs that health care, and it should be affordable. That to me, and I can't imagine anybody at this panel disagrees with that outcome. If you do, please speak up. So I appreciate, thank you for the conversation.
Thank you. Senator Daines.
Ranking Member Crapo, thank you.